Hi, I'm Kelly Edmondson, and I wanted to talk with you today about Tinea corporis. Tinea is common on every single MMO trip, and knowing how to identify and treat this skin infection will help you immensely in your practice. Let's start with the basics about Tinea corporis. Tinea corporis is a superficial fungal skin infection of the body caused by dermatophytes. Tinea corporis can be found worldwide. It is specifically defined by the location of the lesions that may involve the trunk, neck, arms, and legs. Alternative names are used for dermatophyte infections that affect the other areas of the body. These include the scalp, the face, the hands, the groin, and feet. I will be talking about Tinea capitis and Tinea versicolor at a later date. Today, we will focus solely on corporis. Dermatophytes are fungi that invade and multiply within keratinized tissue, such as the skin, hair, and nails, causing infection. Based upon their genera, dermatophytes can be classified into three groups: trichophyton, which causes infections on skin, hair, and nails; epidermophyton, which causes infection on skin and nails; and microsporum, which causes infection on skin and hair. Based upon mode of transmission, these have been classified as anthropophilic, human to human, zoophilic, animal to human, and geophilic, soil to human. As I've already stated, Tinea corporis is exceedingly common worldwide. Excessive heat, high relative humidity, and fitted clothing have correlations to more severe and frequent disease. There are familial and genetic predispositions, possibly mediated by specific defects in innate and adaptive immunity, or those with low defense in beta-4. Children also have higher rates of tinea than the rest of the population. Tinea capitis and Tinea corporis are the most common dermatophytic infections in prepubertal children. Children are also more likely to contract zoophilic infections. Another vulnerable population includes patients with compromised immune systems from underlying disease or advanced age. The immunocompromised patients also have an increased prevalence in developing Majoki granuloma, a type of Tinea corporis folliculitis that invades the deep dermal layers. This will be discussed in another webinar. Other predisposing factors include underlying diseases such as diabetes, lymphomas, immunocompromised status, Cushing syndrome, excess sweating, or advanced age. The currently held view is that a cell-mediated immune response is responsible for the control of dermatophytosis. Patients with tinea commonly present with an itchy red rash on the exposed skin of the neck, trunk, and/or extremities. Feet may start peeling, especially between toes. Remember, these patients are often children and play in the dirt, play with each other, wrestling, and/or play with animals. Symptoms begin 4 to 14 days after the skin comes in contact with the fungi. On physical exam, single or multiple lesions are usually circular or ovoid in appearance with patches and plaques. These annular lesions demonstrate sharp marginations with a raised erythematous scaly edge. The degree of inflammation is variable. In adults, the beard may include scaly, itchy red spots that are crusted over or filled with pus. The affected hair may fall out. The lesions advance centrifugally from a core, leaving a central clearing and mild residual scaling. This appears as a ring shape, giving rise to the term ringworm. Diseases that are in the differential diagnosis may mimic the appearance of Tinea corporis. These also typically present with annular lesions. The clinician must also rule out other more serious conditions, especially if there is severe disease with extensive skin involvement. Common diseases that may present similarly include nummular eczema, erythema annulare centrifugum, tinea versicolor, cutaneous candidiasis, subacute cutaneous lupus erythematosus, pityriasis rosea, contact dermatitis, atopic dermatitis, seborrheic dermatitis, or psoriasis. Some of the severe diseases that must be ruled out are secondary syphilis, mycosis fungoides, or parapsoriasis. Although the gold standard of tinea diagnosis is a skin scraping with KOH, it is perfectly acceptable to diagnose with a simple history and physical. The treatment of dermatophyte infections usually involves the use of topical or oral preparations. Localized Tinea Corporis commonly responds to topical therapy, typically applied once or twice daily, usually for 2 weeks. However, the endpoint of therapy is clinical resolution of symptoms. Suggested topical regimens include one of the following: clotrimazole 1% applied topically twice daily, ketoconazole 2% applied once daily, miconazole 2% applied twice daily, or terbinafine 1% applied twice daily. Please note that topical nystatin is not effective in the treatment of tinea. Oral therapy is necessary in more widespread infections or in cases that have failed topical treatment. Oral terbinafine or itraconazole is usually the preferred first-line treatment and is expected to clear the condition in about 2 to 3 weeks. In addition to terbinafine or itraconazole, you can also use fluconazole or griseofulvin orally. Prognosis is usually good with proper treatment and patient compliance. Complications are uncommon but possible in dermatophytic infections. One such complication includes Majoki granuloma, a condition in which the dermatophyte invades via a follicle and advances deeper into the dermis or subcutaneous tissue. Minor skin trauma such as shaving can predispose patients to Majoki granuloma. Lesions involve the hair follicles and appear as erythematous nodules or papules. These may even progress to abscesses. Oral antifungals such as terbinafine 250 mg once daily for 2 to 4 weeks are the recommended therapies in case of Majoki granuloma. Sometimes oral antibiotics are needed in the case of superinfection from scratching. Cephalexin 500 mg PO 4 times a day for 10 days is an appropriate treatment. Education is important in preventing Tinea Corporis. Patients may be encouraged to wear light and loose-fitting clothing. Wear shoes that allow the air to circulate freely around your feet. Don't walk barefoot in public settings. Clip fingernails and toenails short and keep them clean. Don't share clothing, towels, sheets, or other personal items with someone who has ringworm. Wash hands with soap and running water after playing with pets. Athletes involved in close contact sports should shower immediately after practice sessions, and all gear should be cleaned. Don't share sports gear such as helmets or pads with other players. Teach your patients that compliance with topical or oral medications is important for full healing. The patient may need reminders that even with proper treatment, it may take weeks to begin seeing the resolution of symptoms. Hepatitis is a proven complication with oral antifungals, so baseline liver panel is advised before initiating oral antifungals. Additionally, allergic contact dermatitis to topicals is possible, though rare. I hope you found this lesson helpful. Tune in later for more lessons on Tinea capitis and Tinea versicolor.